Welcome back to In the Archives, where we explore the voices shaping tomorrow's health. My name is Milka, and I'm your host. Today, I'm honored to be joined by my faculty mentor and P3 group leader, Dr. Cynthia Jumper. She's a pulmonary and critical care physician, educator, and advocate, currently serving as the vice chair of the Texas Medical Association of Trustees and as a delegate to the AMA. Dr. Jumper, thank you so much for being here.
You're welcome. I'm excited.
Alrighty. So before we dive into your many leadership roles and all the hats you wear, I'd love to start at the beginning. So what first drew you into medicine, and what made you choose pulmonary and critical care?
Taking care of people has always been one of my interests, and I am from Lubbock, grew up here, and all through junior high and high school, I worked as a volunteer in the private Catholic hospital. It was St. Mary's at that time. Now it's part of the Covenant system, but I worked as a volunteer all 6 years, over 500 hours. And when I went to college, my first degree was a BSN, so I was a nurse. I worked in a small rural hospital, which is now closed, which has really affected along the way part of my pathway. But being the only RN on a 3 to 11 shift in a small town was very eye-opening. And I think I would have stayed in nursing if there were other ways to have grown. So I went back to school to look at a master's in nursing in order to maybe do some teaching and have some academics on the side versus just working at that small rural hospital. But I had a teacher who was a retired pathologist who came in and taught an evening course. And he called me into his office one day after class, which always makes me nervous because I'm not the kind that ever gets called in after class. And he said, "Have you ever thought about going into medical school? Because I think you would make it." And no one had ever recommended that. And he's the first person that really encouraged me to do that. I said, "Sure, why not?" I applied to Tech, was accepted, and here I am. I chose pulmonary critical care due to the people that were in it. It is a delightful subspecialty. You can be as busy as you want to in an ICU, on call all the time, which I was for about 30 years, or you can have an office-based practice in pulmonary and still do general internal medicine. So just that balance of excitement, procedures, critical care illnesses, things going on all the time, but then the option to drop back into an office-based practice if needed is what got me excited about pulmonary critical care.
That's amazing. And I'm so inspired by your career change. You just really shows that there's never a right time for anything. You just got to put yourself out there and then explore.
Correct.
Everything. So in terms of all the hats you wear, you're a physician, you're an educator, you're a mentor, and a leader in organized medicine. What does that balance look for you on a day-to-day basis?
I remind people that you can do everything, you just can't do it all at the same time. So certainly when I came out of my fellowship program, it was all clinical practice all the time. We at that time were probably working about 100 hours a week. There were only 2 of us, and we were trying to manage the pulmonary consult service and the ICU. And Dr. Nugent was one of my big mentors, who is still present and still mentoring students through medical school and residency and fellowship. As I started through that pathway, I really started paying attention to policy. You know, if you just tell me not to do something, I listen, but I don't understand. I want to know why. I want to know the background to it. And as I started looking into policy, it was easier for me to explain to you why we have to do this. Why do we have to have P3? Why do you have to do this? Why do we have to do this? And I think when people start to understand the background, it makes a difference. So I got involved in policy slowly but surely. Now I have transitioned mainly to policy. I'm an executive vice president. Health policy is certainly half of what I do. It bleeds into everything else that I do. I'm no longer rounding in the hospital. I no longer have a continuity clinic, but I still do quite a bit of correctional health care. I go out to an FQHC on Wednesdays and do some supervision. So I'm still involved. I still teach. I'm just not doing primary care or hospital care on a daily basis. So it was a continuum, but I've been on faculty at Tech since '95. Wow. So it takes a long time to be able to get to where you want to get.
Mm-hmm. And as a follow-up to that question, do these roles kind of build on each other, or do you feel like you live in 2 different worlds, clinically and politically?
I think they build on each other because in order to do healthcare policy, you have to know healthcare. Mm-hmm. And I wouldn't have known healthcare if I hadn't been in a small rural hospital. DRGs just came out when I was working in this hospital in the in the late 70s, early 80s. If you don't live it, I think it's hard to try to regulate it or try to police it. And so as I gained experience seeing patients, then I got more involved in the academic side. And then when I became chairman of medicine, I had to really do a crash course in the business side. And so all of that experience has come out now in some of my positions that I carry now on the business end.
Mm-hmm. That's amazing. Now, as the vice chair of the TMA board and as a delegate to the AMA, what keeps you motivated to stay deeply involved in policy while still, I know you're not exactly practicing like day-to-day primary care, but you're still practicing medicine in other ways, such as educating medical students.
So to clarify everything, I rotated off the TMA board of trustees in June.
Okay.
So I could have done an extra 3 years, but we'll get to that in a moment, why I chose not to do the last 3 years of what could have been a 9-year commitment. These commitments are long. So I like a voice in what governs me. I don't like every day to come in and somebody say, do this, move there. We're going to practice medicine this way. You need to document this way. All of a sudden you've got an electronic medical record. I mean, I was at UMC when they first started putting labs on the computer. We used to have to come in early enough as medical students. Our job was actually to call down to the lab and get all the current labs. The lab people hated it. We were getting in at 4:30 and 5 in the morning, making those phone calls, trying to get those morning lab results so we could get them on the charts for rounds. So I've seen the progression of all of that, and physicians were not involved in the electronic medical record. And I think they're very hard to use. They're not intuitive. It was done by computer companies. And so now that we're looking at some AI, augmented intelligence, artificial intelligence, whatever you want to call it, physicians are trying to be a little bit more involved. But we now have electronic medical records where the next hospital over has a different one, your clinic has a different one, the VA has a different one, the FQHC has one, and they don't talk to each other. And they're designed not to talk to each other because these larger companies don't want any of their brand or any of their secrets, any of their technology being found out. So it was supposed to design to be interactive, and it really has not worked out that well. And so I think physicians need to be more involved. We can't just complain. And I will say another reason for being involved in policy is physicians, in my opinion, this is my opinion, we've always just been physicians. We put our head down, we take care of our patients. While attorneys created malpractice suits, while legislators decided on what we were going to get reimbursed, while other people decided what Medicare reimbursement. I mean, if you're a plumber, the federal government doesn't decide what you can charge, and yet they design what we can charge and tell us. And we're one of the few specialties, one of the few careers that occurs. And I just feel like we haven't had a voice, and I want that voice. So I'm just getting more and more involved and really trying to pass that along to students.
Yeah, so thank you for explaining all of that, because I think as a student too, we're not really aware of any of this until someone else tells us, right? Now, can you share a specific moment where your clinical experience directly influenced a policy conversation that you've had in this role that you take on?
Well, there's many. We do a lot of telehealth. We do a lot of correctional health care. You don't want your prisoners on the road being transported. One, they're out of custody on the road. Two, there are guards that are required to travel, and it just puts the public, can put the public at a risk, but it also takes guards out of the prison. But the prisoners also don't like moving around because they like their cellmate. They like where they're located. And if I have to pull them out of, say, Dalhart to come to Lubbock for care, they may get reassigned to another area. So they don't like traveling. So we do a lot of telehealth. And we did last year, I think we had 85,000 just within this group in here, telehealth and correctional. We did 85,000 visits last year. But we developed teledentistry because there are policies that require us to do a full exam on every prisoner that's admitted. Well, Texas Department of Criminal Justice has over 100 jails, 100 prisons within the state of Texas. And you can't have a dentist at every one of those. So we started looking at more teledentistry and how we could do it differently. But then it turns out that in the state of Texas, that it wasn't allowable through their board. So we worked with Senator Perry and got the law changed. And so that was a classic example. There are a lot of examples on policy papers. People can write how they think healthcare should be done within a prison, within a jail, but you've got to work within a correctional system. You're not in private practice. You're not in academic practice. People may say how they want me to teach, but then they have to understand that about 75% of the income to the Health Sciences Center comes from physicians seeing patients. And so you may want me in small groups, but I've also got to turn around and do the billing. And I think if people don't understand that, they can write these great, what we call ivory tower position papers, but you can't apply it unless you've been there.
I'm so fascinated by this teledentistry because I think as medical students in a rural area, we already understand the lack of specialists out in rural areas, but to think of this as even like dentistry is also a realm, like, and imagining what prisoners are going through in these rural areas, it's like they have less access than a lot of people.
One of the other initiatives that we started, and it started because we had so much experience in telehealth. We do so much telehealth that we got national accreditation for telehealth, because if I see you for your diabetes and I see you for your diabetes, but I see you by telehealth and I see you in person, through this accreditation, I've got to document that your outcomes are the same, that I'm not seeing you more frequently or seeing you more frequently, or that there's any inhibition of ideas or of me doing physical exams. I've got to prove the outcomes are the same. And we've gone through that because we do so much through what we call strategic initiatives here. So one of the things that we did is the rural hospitals needed emergency room psychiatry. Where do you take a patient having a psychotic episode? Either to jail or to an emergency room. Those are the last two places they need to be seen. And so there's an organization called TORCH, the Texas Organization of Rural and Community Hospitals. There's 157 members across the Texas state that are considered rural and community hospitals. So if you have a hospital that only has 18 beds, you can't have a psychiatrist in there to see these critically ill in a behavioral health manner. And so they came to us, we set up a program, and we are now doing telebehavioral health through emergency rooms in these small rural hospitals with board-certified psychiatrists. And so we're making that need, but it took us, we had to develop the scheduling. So I think one of the questions later on ask about innovation. We had to develop the software that allows the scheduling of hospitals across the state to call in from emergency rooms to be able to see our psychiatrists and our nurse practitioners that specialize in behavioral health.
Which I'm sure this developing, like in hindsight now you can be like, yes, we developed that, but yes. I'm sure it took so long to develop.
It took quite a while, and we went through the innovation hub here. So Texas Tech's system has set up a way for you to develop what you need to take care of patients, to do whatever. And they have attorneys, they have patent attorneys, and they really work well with you if you can develop something that makes our practice easier.
Okay, that's amazing. Now, with your background in critical care, you've seen firsthand how access and disparities affect patients. How has that informed your advocacy, especially in rural or underserved areas? I know you already mentioned the telehealth, but are there any other examples?
Well, sooner or later, you have to send these patients home. And they usually go home on a lot of medications that they can't afford. And one of the things that I really work with my residents and my students and my fellows is I may give you 4 prescriptions and I'm going to ask you, how do you get your medicines? How do you pay for your medicines? If you are self-funded, you probably can't afford these once-a-day long-acting insulin. And I equate this to my residents. They always say, well, this patient's non-compliant because they didn't take the $2,000 antibiotic that we prescribed for them to take when they went home. And I would see my own patients coming back to me in the free clinic where they couldn't afford their antibiotic because no one asked them how you're going to get that antibiotic. So I think that's important. And we want them in rehab. Well, rehab won't take you if you don't have funding. And then we send you back to your home base, which may be 100 miles from here. And we want your lab the day before we see you. Well, now you've got to drive in, get the lab done, drive back, and then come back into our clinic. And so looking at all of those, social determinants has become almost a 4-letter word. People don't want to hear about it, but it affects our outcomes. I can't see you and give you state-of-the-art care and not have any idea if you're going to be able to attain that, because the outcomes matter. And that's one of the things with some of the software that we developed in correctional healthcare. I've got 30,000 prisoners just in the Texas Department of Criminal Justice under our care, I can pull up a dashboard on that computer over there that will tell me their hemoglobin A1C every month. I know for population health what all 30,000 of mine that have diabetes, what their average hemoglobin A1C is. I can get it down to the region, I can get it down to the prison, and I can get it down to the provider that's taking care of them. And that's what you've got to start looking at for these outcomes, because if those outcomes are not what you need, I feel like I can't just keep seeing them and prescribing the same thing and the outcomes not being what they need to be, but you've got to have a way of looking at what those outcomes are. And it's harder in rural health because they don't have the people there. They have an uneducated family. Send somebody home with a glucometer. Well, that's easy unless somebody can read in that family. Send somebody home with pain medicine and they have an addict in their family. You send somebody home and want them to come in for twice a week rehab because they had a fractured hip. They can't do that. So how do we get that done? So it affects my care in the ICU. It affected my care in the prisons. It's affected my care all along the way. I want to know the care that I provide, how is someone going to be able to do that? And so that's where I start looking at policy. We do telehealth physical therapy now. Is it the same as me taking your arm and doing this? No, but is it better than you going home and being bedbound because no one's looking after you? So we do everything that we can for rural health.
Yeah, and I feel like anything is something.
Yes.
At the end of the day. So that's an amazing stride that you've contributed towards.
Mm-hmm.
So here at the Ark of Hope Foundation, where students focus on teaching, advocacy, and outreach in the community, especially in our local Lubbock community, we're always asking how we can make a difference. So from your perspective, what role can medical students play in recognizing and addressing health disparities early on in their career?
To me, and I had to think a lot about that because y'all are so full of energy, so full of hope, so full of great optimal ideas, that after 10 years, very few of y'all are doing any of that. And I say you, it's not you. But, I look at this in the organizations. The American Medical Association, the Texas Medical Association has very robust student representation. Great for medical students, for residents, for fellows. It drops off so much in early career. We can barely get enough people to form an early career committee. Now you're out there. If you don't see that patient, you don't get paid. And so you can't be taking off to go to meetings. You can't be at night. Now you're having a family. I have Zoom calls probably 4 nights a week now. And if you have small kids, you can't do that. But that's what it takes to be higher up on a lot of these organizations. And so it falls off, and that bothers me because y'all are the ones with these ideas. We're the ones that say, well, it was never done that way, or we always did it this way, or it wasn't done that way when I was young. And then you with the great ideas, y'all just get so busy, as you should. And like I say, you can do everything, just not at once. So we can figure out a way to keep some of that momentum going when you are young physicians, which it used to be up until you were age 40, but now they've extended some of these fellowships so much that I think we call it under 8 years of practice, early career. But finding a way to make that transition is just vital.
Yeah. I've never thought about it that way, and so that is really interesting to hear from someone else because I think we all do have a lot of these ideas, but we don't understand the reality of it until we're in it.
The passion's there, and the passion doesn't die out. It's just replaced by day to day of making a living now and not having the luxury of that time. So I tell you, don't think you can do it all, but stay on one committee. Just one committee, and just try to keep that up while you're starting out. Get your Lubbock County Medical Society. Look at just one thing that you can do. I didn't start out on day one with all of this. I built it up slowly.
Right. That's very good advice. Thank you. Now, you've been a mentor to many students, and you've also served as many executive roles, especially within medical education. So how do you see medical training evolving in the years ahead?
That's a loaded question. I started medical school here in 1984, And it was the same forever and ever, shortening what I don't even want to call it the basic science. I mean, we had 2 years of basic science, 2 years of clinical science, and you did a residency program. So, so now they're shortening that time. The curriculum's kind of still the same. I mean, science is science. Seeing patients in the hospital, you still have to know history and physicals. You have to know differential diagnosis. So that data's the same. How we teach that may be a little different now. I know that I used to give an hour lecture on the pleural disease. And now I give a 10-minute lecture on pleural disease, and then anybody has a question will come and ask me later. And it was good for me because it really made me cut down to what's the 10 most important things that I can get in this 10 minutes. So I think the way that we teach, I've always wondered why we don't find an expert teacher, and I'm just going to say Columbus, Ohio. I don't know anybody there. And they may give the best lecture on pulmonary physiology. Why don't we have that person give it? Why are we always trying to get a clinician out of clinic to go and give that talk? Why are we always trying to get a PhD who's really being pushed to get their NIH funding and in the research to come and give that talk? And then if somebody's sick, they're calling you, hey, can you give this talk? So I think we'll see more and more some best practices, some best lectures. I know y'all have a lot of review books now, which we didn't have. I know the school pays for a lot of different review type products that we didn't have, and certainly I don't think the school would have paid for it. So I think that's changing. I would like to see y'all interact with patients more. The fourth year of medical school has always amazed me because it's not very full, but it gives you time to interview, it gives you time to travel. But I get you July the 1st in the ICU, and you haven't been on call, you haven't seen a night, you haven't, and also, you've got ventilators running in there and vasopressors, and it worries me coming off that fourth year some. So I would like to look, one of the things that the AMA really is looking at, the Council of Medical Education for the AMA, is looking at these transitions, transitioning from medical school into residency program, transitioning from all that training into practice. What should that transition look like? They are governed by different governing bodies. They are funded by completely different funding mechanisms. There's none of this. Medical school, state. Graduate medical education is more federal or private. And the two don't do this very often. So one day you're a medical student, and one day you're a resident. And a lot of people make that transition easily, some don't. And so looking at how we can do those transitions better.
Yeah, that is a really great point. What specific qualities, I guess, in today's students gives you hope for a better future of medicine?
I want students that take ownership of a patient. If you think about how we have fragmented our care now, because you can't be on call for too long. So somebody admits you at night, you're the patient. And remember, I grew up here, so my family has their care done here. I take this very seriously. You're admitted at night by one team. You get picked up by the team the next day. It may be August 31 and September 1st, you get a whole new team. And we fragment that care. We have hospitalists who don't take care of you in the, in the clinic. And the hospital has a policy, you've got 30 days to do a discharge summary, but I'm going to send you back out to your primary care in 2 weeks. I used to handwrite a discharge summary and give it to a patient for them that were going out to Lockney or back out to Pampa so they could give it to their primary care. Turns out that was against policy and they didn't like that. But how else do you, I want students that will just take ownership of that patient. It's my patient. I need to be able to see what happens. And oftentimes we don't see what happens. You rotate off a service, somebody else comes on. You don't know if that person gets better. You don't know if that person ever goes home and lives independently. You don't know. So I want students that really want to take ownership of that patient, but continued curiosity. Yeah. Curious, what's the process for this? How are we doing that? How are we making sure that patient can afford those medications? How are we making sure that patient has a ride to come back? When I had a continuity clinic or when I supervised residents or fellows in a clinic and a patient didn't show up, I made them call them because I want to know why the patient didn't show up. And you hear the saddest stories at times. They're on Medicaid and the taxi couldn't get there, or they're trying to, they were trying to get to the bus depot to even get downtown to where our clinics are, and the buses weren't running, or a family member just died, or they didn't have the way to come in to get the tests that I ordered pre-clinic. And so they didn't feel like they should come in. Very few of them just, there's one or two that they just don't care about their health, but most of them do. And so I made them all call them and say, we missed you at clinic. What can I do for you? Because here's what happens. You'll need your medicines refilled. And I'm going to look, well, you didn't show up at your clinic appointment. I'm not going to refill your medication. How does that help someone? To a certain extent. So, what can we do to help you? What can we do to get you back in the clinic to be seen? How can we follow that? So I want students to think about the patient as a whole. And I want people to think about how they would like their care done. And I want continued curiosity. How could we do this better? Why do we do it this way? If we did it a different way, would it make a difference?
That's beautiful. And I think that's a really important point for especially our viewers who are pre-medical students or medical students that want to become physicians eventually, to really try and have that characteristic when they're practicing, because, there's a difference between doing the job just to get paid versus doing it because you genuinely care and you genuinely want to do it. And that altogether makes the greatest difference in the care that the patient's receiving as well. Yeah, and so moving on to more of like the technology and access realm of what you're involved in, you've spoken about the importance of bridging technology and access to care. So how is our school's technology expanding or helping expanding healthcare in West Texas?
I think with telehealth is one of the big ways of doing it. The other thing that's really helping us is, we're training. I just went on a 2-day, 8-hospital, rural hospital tour with Cole Johnson and with Smiley Garcia. And almost every provider, every physician, every nurse practitioner at those small hospitals trained at tech. Or they came from those areas and went back to those areas. And we have to think about that. I just don't think I'm ever going to get somebody from Long Island, New York, really want to come and practice in Shallow Water, Texas. You'll get me to practice in Shallow Water. So we have to look. I think that's some of the technology, some of the innovation that we're doing. Family Medicine out of Odessa has a great program where where the towns are invested. I think Alpine's one of the towns where they will pay the salary for a year. So I'm not in this department, so I'm sure I will get part of this wrong, but they'll come in and do like 1 year in the Midland Odessa residency program, and then they'll go out to Alpine, Fort Stockton. They've got some different towns where they go out and then practice in that town, finish their residency program under the guidance of a private practitioner out there, and then they're more likely to stay. And usually students that do that. So I think innovation, but then we have to do distant education. We've got to be able to have them sit through classes that we're teaching here. I think now, students don't always have to come to class, sit in class now, because we have so many other ways of doing that. I walked into the classroom, is it on the second floor of the D-Pod, where it's all tables that will seat 6, and each one of them has a big screen, and just watching how that works. That's how we teach now. It's harder from the pulpit up front, to give that individual thing, but it takes a lot of individual faculty to do that, which is a little bit more difficult. But I think that's how we're using innovation. One of the things that we've done in correctional health care, if you just want to do, say you're doing telehealth, and I've got some of my School of Nursing faculty who do their practice with us, so they give me, I think, 16 hours a week, and I just put them in front of a computer. And then I've got 31 different prisons, and and then on the back side with the computer software that we developed, they can see, a patient from 4 or 5 or 6 of the different prisons, just one after another. And that's really made a difference, because I can't get sometimes people up to Dalhart or people over to Fort Stockton or people out and about, but I've got somebody sitting here that can see them by telehealth. But the logistics of getting them in front of the providers, it took a lot of innovation in digital medicine.
Yeah, no, I'm sure.
Yeah.
That's amazing. Now, You have held so many leadership titles, as we've mentioned quite a few times, but which role has been the most transformative for you personally, and why?
I thought long and hard on that when you asked me that earlier. They were each vitally important at the time. I don't think I would have ever jumped to what I'm doing without going through these other steps. I went to a junior faculty leadership program for women that a dean about 4 deans ago sent me early on, and they gave some advice that you need to be noticed in order to get on these committees. You know, you can't just sit back and say, well, nobody chose me. And they suggested I was on different committees because I've always been community involved, and I was on a biohazard committee. I may or not been on a library committee, but they said you need to be on a committee as a junior faculty with the dean or with the chair. Well, no deans and no chairs are on the committees. So the next year I volunteered and got elected onto a committee where the dean attended the thing. And I happened to sit by him because we didn't have cell phones, and we had these verbal beepers, and I had to sit toward the back so I could step out to answer all the calls. Well, he sat at the very end because he came in late. He learned my name, and from then on, he put me on different things. So one's not more important, but I had to start someplace. And I tell everybody that I didn't really have a career ladder. I had more of a jungle gym. I kind of started here and I slid sideways, then I went up, then I may have gone down a little bit, and then I went, over, and it was never planned. I know there have been people in my life that I'm going to do this step, and this step, and mine is I'm going to try everything, and what I'm good at, I'm going to stick to, and what they want. I was involved in a lot of national organizations, and I volunteered for every committee, and there were some I never got picked on. But in the Texas Medical Association, I volunteered and I got picked. So I went on a cancer committee, and I went for 6 years, and all of a sudden I'm the chair. And then the next thing, I got put on a medical education council, and I sat through that for 6 years, and my last year I was the chair because I show up. And then that got me noticed, and I ran at the AMA, you have to get elected to those councils, and that was an 8-year stint at the AMA, and the last year I got to be chair. So one's not more important than this one, but it builds on what you do. There's a few people that can go straight to the top, but I had to take all these little steps. And it made a difference. So each one was the most important at that time. And everybody asks me what I want to do next. And I tell them I don't have any plans for next. I want to do this job to the best of my ability, and just, I could retire at this job. But if something else comes around, I'll take a look. Not outside of tech. My future's tied to tech, so in my hometown here. So it is. Yeah.
And I know a little bit earlier you mentioned that you're actually not on the TMA
Board of Trustees
anymore. You left that position in June. So can you expand a little bit on why you made that decision?
I made that decision for 2 reasons. One, I do a lot of policy, but it's self-learned. And I have a 4th-year health policy elective that I do, but I created the curriculum. I do this, but it's still self-taught. And I really wanted to be able to, I don't have a master's in public policy or in health policy. There was a program that was started, that's just starting, out of Brandeis University in Boston. And it is taking 25 physicians across the nation and putting them into a health policy fellowship that's a hybrid for over a year. And so there is what I was just showing you when I ran off, that's the reading. So I already had an orientation. I will go to a week-long class in Boston at the end of September. Then I will spend 1 Saturday a month on Zoom calls, and I will have small projects, and I'll go back to Boston. It lasts for a year. But I feel like that will give me what I need to be more secure in this policy. When I make policy now, I'm surrounded by staff that trained in policy. And so while I can give you, well, I don't think that will work, or I think we should look at this, they're the ones writing it. They're the ones coming back and saying, well, did y'all think about this? And so we write a lot of policy papers, especially through the American College of Physicians, because I'm on their health and public policy committee. So we write a lot of policy, but for I say for every position in there, I think we've got 2 staff members who have these PhDs in policy and who have all of this. And so I wanted more of a formal education, and I got accepted to that program.
Congrats.
And thank you. I'm really excited because there's only 25 of us. And I also got accepted for a full scholarship. So the $40,000 Tech does not have to provide for me to do this. All my travel will be paid for. I had to get permission from my president, but that's going to take a lot of my time. And so I just didn't feel like I could really devote, I was on the board of trustees when we went through the pandemic, and we met every week because we had to run the TMA because the House of Delegates couldn't meet. And so a lot of stuff, it was just going, it's a lot of business. I loved it. I loved the people on it. I loved what it did, but I felt like I'd been on it for 6 years. And you can do three-year stints but you have to be elected, and it requires quite a campaign. And I just didn't want to campaign, and I really wanted to devote myself to this fellowship. And so that's what I'm doing. And then I'm also one of the Texas governors for the ACP, and that is their policy piece, like the House of Delegates for the TMA and the AMA. Their board of governors is what does all the policy for the ACP. And so I represent part of Texas for that. So I've gotten better at looking at where my energies can be.
Dr. Jumper, you are on fire.
Well, I want to do things well, and sometimes I've got to do less things. And I was becoming one of those people that I used to get mad at because I was on the board of trustees. I'm a delegate to the AMA. And I remember looking, I said, why do the same 20 people have all the jobs? They don't just have one job, they all have 4 different jobs, and the younger group can't get elected. And so I also looked at that. There's a lot of smart physicians coming up, and a lot of people use that board of trustees as a springboard to be president of the TMA, and that was never one of what I wanted to be. I like behind the scenes, behind the camera. I like doing the policy piece. I don't want to be the spokesperson. So that was never what I wanted to do. And I wanted somebody else to be able to come in that really wants that. And one of my friends from Amarillo is now on the board of trustees. So I want to make sure West Texas is well represented. And so after he got elected is when I decided I wouldn't run again. So then it will allow me to do these other things now.
You left it in good hands. So
I did. But
also it's so important because you're still able to fill your cup and you know when to pull back. And I think that's a really important quality for students to really realize as you're going into this field that it's very easy to get burnt out. And so to step back when you feel like you want to move towards something else and commit towards something.
I teach I do classes, nothing against guys, but I think more like women. And so I have a leadership slide deck for women, because we do think a little differently. But I talk about you climb this ladder and you do all this stuff to get here. And then they want you to be an executive. And people tend to stay on that same ladder. And when I became chair of internal medicine, I was still rounding in the ICU. I was still doing all the teaching. And I didn't want to give any of that up because that's what I trained for. That's what I was good at. That's what I felt most comfortable at. But it weighed me down. And I showed this person going up the ladder with now these weights on their legs. You've got to get on a different ladder. Now you're on an executive, administrative thing, and it's a completely different, and you've got to shed some of the stuff that got you there. One, I need to make room for people like y'all to come along and get these leadership positions, but 2, I need to focus some of my energy on the new ladder that I'm on. And so you've got to be able to give something up to take something else on if you're going to do a good job.
Yeah, that's amazing advice.
You have to protect your own energy level. So
yes, protect it.
Because nobody will do it for you.
Mm-hmm. Yes, and you are your biggest advocate.
Yes.
Just looking ahead, what gives you confidence in the next generation of physicians?
When I was in medical school, we never really talked about the social aspects. We didn't start a free clinic for homeless people. We didn't start a food bank, which the school has now. We literally came to class and learned and went home. I think the fact that y'all are so involved and you see that there's something outside of just class is what gives me hope. You know, when you look around, we didn't do that. And it wasn't that we weren't bad people. It just, I don't know, we just didn't do it. And not many people did. You didn't hear about free clinics in 1980, 4 whenever I started. And so I think the looking around, what's going on in the community. And when I look at applicants for like our residency program, one of the things I ask students is, what did you do? You know, I don't really want someone who moved here just to go to school and didn't do anything with the community, because I want you to take some ownership of where you are. So I always ask, you know, what did you do outside of your training? What did you do outside? They're better well-rounded. They look outside themselves. It's not just me, me, me. And I think that's important. And that's what gives me hope, because y'all do that so well.
Well, I'm glad to hear that
Yeah.
from someone that gives us all our advice.
Yeah.
As a closure to our podcast, if there were one issue you'd want medical students to lead the charge on in the next decade, what would it be?
Oh my gosh, one issue. I don't know. You know, they always tell you to find your passion, and I struggle because I love medical education. I love patient care. I love advocacy. And I finally found a TED Talk one time on a woman who said she had 12 passions. And they always say, well, you can't have 12 passions, but you can. You know, I can't pick one over the other. And so we need people that want to take care of patients, but we also need people that want to take care of physicians. And physicians can't make a living if Medicare has dropped us over 30% in the last 20 years in our reimbursement when taken, you know, into account for inflation. We can't make a living if I have to hire one person just to document some things that I can get 1% more in reimbursement through Medicare. I can't make a living if the revenue cycle is so complicated. And these poor patients, they need a navigator. Like I say, I'm from here. Trying to get my family through healthcare here can be a full-time job. And it requires quite a bit. So I want someone to take care of the patients, but I really want someone to also help take care of the physicians and everything that goes into the business aspect of taking care. And that comes best from a physician. So it comes best from physician advocacy, patient advocacy, you know, the families trying to take care. Most of them really want to take care of a patient, you know, want to take care of their family. They don't have the means. So my passion is almost everything connected to healthcare education and healthcare delivery, from the business aspect to the bedside aspect to developing new innovative ways to provide care. People don't realize when you're in a wheelchair, I'd have to get a wheelchair van to get my mom, you know, I'd almost have to take off work just to get her to come in and spend 5 minutes with a physician, you know, I mean, you know, get them dressed, get them in a wheelchair van. All of that, people just don't recognize until you have to go through it. So all of that is my passion, and I want to pass that on to everybody.
That's amazing. Well, thank you so much, Dr. Jumper, for joining us today on our episode, teaching us so much about healthcare advocacy and being a well-rounded physician. We're so grateful for your amazing advice. But other than that, we'll see y'all on our next episode of In the Archives. Bye.
Bye.